So it's important to note that a maintenance strategy improves survival, specifically for patients with advanced lung adenocarcinoma. And I have been very much a proponent of maintenance from the start. I think patients who are on a good therapy, if they're doing well and tolerating that therapy, they should continue that therapy until either toxicities or disease progression. So a little more granular would be that I generally, for my lung adenocarcinomas, I give them 4 cycles of carboplatin pemetrexed. And if they have at least stable disease after 4 cycles, then I will drop the carboplatin and I will continue the pemetrexed. There are times that in some cases I'll use bevacizumab as well, so carboplatin, pemetrexed, bevacizumab. After 4 cycles, if at least stable disease, I will continue the pemetrexed and the bevacizumab. But I would say for most of my patients, I use a carboplatin, pemetrexed backbone. And it's important to note, there's been I think some incorrect data out there, or a perception that if patients don't have a response after 4 cycles, then they should not get maintenance. And that's not true. They just need to have at least stable disease and tolerating the treatment. We'll generally drop the carboplatin after 4 cycles and continue the pemetrexed every 3 weeks. And I think we've seen in the data, at least with cisplatin, the Paramount data, that improves survival significantly versus no maintenance. There's a lot that I think goes into treatment options for maintenance. It's very important that after 4 cycles, that the patient is at least tolerating the treatment. If patients aren't doing well or having toxicity, maybe that's not the right patient for maintenance, or maybe that's the right patient for a treatment break with a reinitiation of maintenance at some point. So I think that's one. And secondly, I mentioned is, if patients have progressive disease after 4 cycles, you give them 4 cycles and their tumor is growing, that is not a candidate for maintenance. Those patients probably need to go on second-line treatment with something else, either immunotherapy or another cytotoxic regimen with or without an anti-angiogenic strategy. So I think importantly, one of the things that I'd like to do with my patients is have that discussion about maintenance at the beginning of the treatment. So I tell patients, you're going to get 4 cycles of a platinum doublet with pemetrexed. And if you're doing well and your cancer has at least not grown, it stayed the same size or shrunk, we will continue we'll drop the carboplatin and continue on single agent drug. So that after 4 cycles, there's no confusion or curveballs for patients. They're aware of the plan, they understand it. So I think it's very important to have that discussion up front.